A very good afternoon to each and every one of us. Thank you for joining us this lovely sunny afternoon, and welcome to the Scrutiny Board of Adult Health and Active Lifestyle. Abigail Marshall Katung is my name, and I chair the board. Do excuse me when you see me floating between two devices at the moment. I've got a bigger screen, and that's what I'm using right now. So at this point, I would like to point and clarify that while this meeting is being webcast live to enable public access, it is not being held as a public meeting in accordance with the Local Government Act of 1972. As such, it is a remote consultative meeting of the Adult Health and Active Lifestyle Scrutiny Board. The consultative status of today's meeting means that some of the usual formalities will not take place at the start of the meeting. And while it also means that the board will not be in a position to take any formal decisions, today's discussion will still very much help inform the work of the scrutiny board, and where necessary, any proposed actions that do require formal ratification will be referred to the next formal public meeting of the scrutiny board for approval. So I would like to invite board members to introduce themselves, but I would like to remind everyone to please mute their microphone after they have spoken throughout the meeting. I would now like to invite members of the scrutiny board to kindly introduce themselves, and we would love you to do that following the alphabetical order of Councillor Anderson.
Good afternoon, everybody. I'm Councillor Caroline Anderson. I represent Adeline Wharfdale Ward.
Thank you. Dr. Beale.
Good afternoon. I'm John Beale. I chair Health Watch Leeds, and I'm a co-opted member of this board.
Thank you. Councillor Burke.
Hello, everyone. I'm Councillor Sharon Burke, and I represent Middleton Park Ward.
Thanks for joining us. Councillor Farley.
Hi, I'm Councillor Luke Farley. I'm one of the Labour representatives for Bournemouth and Richmond Hill.
Thanks for joining us. Councillor Gibson.
Hi, everybody. Councillor Gibson, and I represent Crossgates and Winmore Ward.
Thank you, Councillor. Councillor Harrington.
Good afternoon. Norma Harrington, Wetherby Ward.
Thank you. Councillor Hartbrook.
Hello, everybody. Councillor Conrad Hartbrook, Rothwell Ward.
Thanks for joining us. Councillor Iqbal. Councillor Iqbal, are you there? Right, I'm going to jump him. Councillor Kidger. Councillor Kidger, are you there?
Unmuting. Hi, sorry about that. Couldn't get my button pressed.
Right.
Councillor Wynne Kidger representing Morley South. Thank you.
Thanks for joining us. Councillor Taylor.
Good afternoon, Councillor Taylor, representing Chapel Allerton Ward.
Thanks for joining us. Councillor Thompson.
Good afternoon, Councillor Eleanor Thompson, representing Guiseley and Rawdon Ward.
Thanks for joining us. Can I ask if Councillor Iqbal is back on now? Okay, I will tell you where he represents. So his full name is called Councillor Mohammed Iqbal, and he represents Hunslet and Riverside Ward. I will now invite our Principal Scrutiny Advisor to introduce himself.
I'm here. I'm sorry, I'm here.
So what happened?
Somebody was at the door. Sorry.
Okay, I'll let you off. You can now reintroduce yourself, because I've already done so, but do so in your own voice.
Okay. Councillor Mohammed Iqbal, Hunslet and Riverside Ward. Apologies for lateness.
Apologies accepted. Thank you. Right, Stephen, back to you to introduce yourself.
Thank you, Chair. Stephen Courtney, Principal Advisor for the board.
Thank you very much. I would also like to all let you know that just in case I've got any difficulties technically, Councillor James Gibson will take over whilst I try to join you again. But hopefully, fingers crossed, I should be fine. Okay, so thank you all again. And straight to agenda item number 1, declaration of interest from board members, please. We got any? Can you nod properly so I can see you on the screen? That's it. Thank you. Right. Agenda item number 2, minutes of the last meeting. Our last meeting was the 21st of June, 2022. Any matters arising from that? That's not covered in today's agenda. Can I get a thumbs up if you're all fine with that? Fabulous. Thank you very much. Okay, Stephen, do you want to come in with your update, please?
Yes, Chair. Just a general update, just to advise members, just in terms of the implication or implementation of the Health and Social Care Act 2022. The briefing note that I provided to members has been circulated, and also in relation to minute number 9. It's not specifically related to this board, Chair, but for members' information, there have been some changes to terms of reference for other boards. So they specifically relate to the functions of the Director of Resources that relate to Civic Enterprise Leeds and the Community Infrastructure Levy. And both those elements have been removed from the remit of the Environment, Housing and Communities Board and put within the remit of the Strategy and Resources Board and the Infrastructure Investments and Inclusive Growth Board, respectively, Chair.
Excellent. Okay, thank you very much, Stephen. Right, we're moving straight on to agenda item number 3. For all those who have joined us who are non-members, please, if you are feeling uncomfortable, do send a private message to myself or just put it on the group chat or myself. We'll pick that up, okay? And if you need 2 minutes to go get water, because you all need to remain hydrated, all right? It's very, very important at this time. So please do let us know if you need a glass of water. But I can't bring it to you, but I'm sure you can help yourself in your homes. Right. Agenda item number 3, visiting policies and patient advocacy within local healthcare and care home setting across Leeds. Would you like to do the introduction, Steve, please?
Thank you, Chair. Yeah, so during the previous municipal year, the last scrutiny board identified the visiting policies and patient advocacy arrangements within local healthcare settings and care homes as a specific topic for the successor board. So the report that's been presented and its appendices present a range of details provided by health and care providers and other partner contributions across Leeds. These include the City Council, Leeds Teaching Hospitals Trust, Leeds and York Partnership Foundation Trust, Leeds Community Healthcare NHS Trust, St Gemma's Hospice, Sue Ryder Wheatfields Hospice, Martin House Children's Hospice, Leeds Care Association, Carers Leeds and Health Watch Leeds. And we've got a number of representatives to provide an update to members of the board. It might be helpful at this point, Chair, to ask those present just to introduce themselves briefly and then give a brief introduction to the report, Chair.
Thank you very much, Stephen. Okay, I believe Councillor Jenkins, you're standing in for Councillor Venner. Is that correct? If you could kindly introduce yourself, please.
Okay, thank you, Chair. My name is Councillor David Jenkins. I represent Killingbeck and Seacroft, and I'm a Deputy Exec Member for Children's Services, Adult Services, Adult Social Care and Health Partnerships.
Thank you very much for coming. Next will be Caroline Barrier.
Hello, thank you very much. I'm Caroline Barrier, Deputy Director of the Integrated Commissioning based in the Adult and Social Care, Adults and Health Directorate of Leeds City Council, but also in an integrated role with the NHS.
Okay, thank you. Could everyone hear Caroline? I struggle to hear. Is it me? So you might need to speak closer to your microphone, Caroline.
Okay, I'm really sorry. Can you hear me now?
I can.
Brilliant. Okay. I'm Caroline Barrier. I'm the Deputy Director for Integrated Commissioning based within Adults and Health Directorate of Leeds City Council, but also in an integrated role with the NHS.
Thank you very much for joining us. Okay. Next we have is Sarah.
Good afternoon, everybody. I'm Sarah Munro and I'm the Chief Executive of Leeds and York Partnership Foundation Trust.
Thanks for joining us. We've got Steph.
Thank you, Steph Lawrence, Director of Nursing and Allied Health Professionals at Leeds Community Healthcare.
Thank you very much for joining us. We've got Heather.
Hi there, I'm Heather McClelland. I'm the Chief Nurse at St Gemma's Hospice in Leeds.
Thank you very much for joining us, Heather. Okay, from Health Watch, we've got Harriet.
Hello everyone, my name's Harriet Wright and I'm a project worker at Health Watch.
Thanks for joining us. Andrew?
Hello, I'm Andrew Patterson. I best described as a service user. My wife is resident in a care home in Leeds.
Thank you for joining us, Andrew. From Leeds Care Association, we've got Michelle.
Hi everyone, I'm Michelle Atkinson, Chief Officer at Leeds Care Association.
Thanks for joining us this afternoon. Okay, we do have apologies from the Integrated Care Board in Leeds, Martin's House Children's Hospice, and Sue Ryder, as well as Carers Leeds. Is that correct, Stephen? All of them sent in their apologies.
That's correct, Chair. We also have representatives from Leeds Teaching Hospital Trust as well, Chair.
Okay, would you like to introduce yourselves, please, if you're here?
Hi, good afternoon. I'm Jo Regan. I'm Director of Nursing at Leeds Teaching Hospitals Trust.
Hi, Jo. Thanks for joining us.
Thanking you.
Thank you.
I'm Rob Newton. I'm Associate Director of Policy and Partnerships at Leeds Teaching Hospitals.
Thank you, Rob. Great to see you. Right, who else have we got?
I'm sorry, I don't know who's here. I am Tom Everett. I'm a consultant obstetrician, the lead clinician for the maternity services at Leeds Teaching Hospitals.
Excellent. Thank you very much for joining us. Is that everyone from the Leeds Teaching Hospital?
It is for this item, Chair, just to confirm that Dr. Everett's attending for the next item, not this particular item, Chair.
Okay, excellent. Thank you all for joining us. Right, okay. I would now call on Caroline to introduce the information presented to us in our packs. Over to you, Caroline.
Thank you very much. I don't know, I think actually Councillor Jenkins wants to say.
Sorry, Caroline, you need to come closer to your microphone.
Okay, I'll just bring my screen closer. I do apologise. Can you hear me?
I can hear you now.
Okay, I didn't know whether Councillor Jenkins wanted to come in first, but happy to otherwise.
Yeah, he looks keen to come in. Councillor Jenkins, over to you.
Okay, thank you, Chair. So this report outlines the approaches taken across the health and care sector in Leeds during the course of the pandemic in relation to visiting arrangements for people who've been inpatients in a healthcare setting or residents in a care home setting. The arrangements for visiting have been kept under constant review and have been revised and updated as the guidance has changed through the past couple of years. This has, of course, been a particularly sensitive matter because our health and care settings have had to balance the huge benefits that visiting brings for people in terms of their emotional well-being with the risks of spreading the COVID-19 virus. Considerations and arrangements have had to be put in place, particularly for people that are at end of life or people that have dementia or were contact with their families, members and loved ones, where contact with their family members and loved ones is so critical to their well-being. As you'll see throughout the report, the various health and care teams have worked together to reduce the risk of transmission of the virus and to protect those people who are at most risk due to their health and care needs. At the start of the pandemic, systems were set up as part of the health and care response, and significant focus has been given to visiting arrangements and patient advocacy during the various stages of the pandemic, and particularly after the strict lockdown measures began to ease. I will hand you over now to officers, particularly Caroline, who will be able to give you more information about how visiting arrangements and patient advocacy have been considered and implemented over the past 2 years.
Thank you, Councillor Jenkins. Back to you, Caroline.
Okay, thank you.
Okay, Caroline, you're frozen. Okay, is there anyone else from on this agenda item that would like to take over? And then if we're able to reconnect with Caroline, I'm sure she can come back.
Sorry, Chair.
Yes, Councillor Farley, yeah.
I think it seems like Caroline's got having an issue with her internet connection. I was just wondering if we could get her to dial in via a phone. Maybe that would provide a better. We'd at least be able to hear her.
Yeah, could I ask any of our back staff to please try and see if you can help Caroline whilst we continue with our agenda, if that's okay.
We'll sort that, Chair.
Thank you. I am happy for any of the other officers or staff from the Leeds Teaching Hospital. If you want to speak now, we're happy for you to speak. Before we move on to the Leeds and York partnership officers. So any one of you, Joe or Rob?
Yes.
Hi. Do you want me to, Rob? Do you want to? You go first, Rob.
No. Well, I was just going to say. So Joe, as a director of nursing, has led lots of our visiting arrangements, and will be able to talk through the process and the decision-making process for our policies throughout the pandemic, if that would be helpful.
Okay, thank you. Over to you, Joe.
Okay, thank you. So you'll have read the paper that outlines the Leeds Teaching Hospital Trust. We had quite a robust arrangement throughout the pandemic in terms of visiting. So as Rob said, I led on some of the aspects of visiting and reviewed the national guidance that came out. And from the national guidance, we followed that. But all the changes to any guidance, whether it was either to relax the visiting or to actually restrict the visiting further, depending on where we were with COVID, anything that was suggested actually went through our clinical advisory group, which was a group that was held weekly in the trust. And on the membership on there was our chief nurse and our chief medical officer. So all the guidance specific to Leeds Teaching Hospitals Trust was agreed through that process through our clinical advisory group.
Okay, thank you very much. Will anybody else like to add to that? And could I also ask board members, as you listen to what they're saying, please kindly pay attention to that, because whatever they will be presenting to us, we would like to see if there's anything more we would like to pick up in our scrutiny activities for the rest of the year, if that's okay. Have we got any questions for Joe from the presentation? Obviously, you've got that in your packs.
Chair.
Yes.
I'm conscious that the other attendees that would have, so we obviously have inpatients who might also want to comment, following on from Joe's update, but happy to take questions just to LTHT if that would be helpful. I guess just to reiterate what was said at the beginning in Joe's comments, just to emphasise how difficult it's been and how sensitive a topic this has been, and how much uncertainty Joe and the team have been working under throughout. It was certainly uncertain at the start, and it's not as if what's happening with the pandemic has got any more certain as it's progressed. So it's been a hugely complex thing to manage, and also we've tried as a trust to be as flexible as we can. So during times in the pandemic where infection rates have increased and infection rates have dropped, we've attempted to change our visiting policies as appropriate, mindful of the risks of doing so too soon or too late could bring.
Okay, thank you very much, Rob. We do have questions, but we will wait until it's time for that. I believe, Caroline, you're back with us now. Fabulous. All right, over to you now.
I'm ever so sorry. I have no idea why this has happened, but my internet just crashed. I've got my Sky box there, so fingers crossed broadband remains.
Don't worry, it's okay. Blame it on the heat. Yeah, carry on.
Okay, so what I was saying was that right from the start of the pandemic, we came together as a health and care system, but also and really importantly with our third sector organisations and our care and support providers. We set up various command meetings, gold, silver and bronze, and we had a bronze command meeting specifically around support to care providers and care homes in helping them in managing the COVID virus by reducing infections, so infection control, prevention measures, but also supporting them with the guidance as guidance changed throughout the lockdown periods and then out of the lockdowns. And part of that included support in relation to supporting family and carer visiting in care home settings. We did a whole range of work in terms of accessing funding from central government, specifically around digital access. We allocated iPads to various care homes and also put in the support to help them with connectivity with families. And that was particularly important during the height of the lockdowns when face-to-face visits were not permitted. Very quickly after that, we supported care homes around window visiting and then outdoor visiting, setting up shelters, etc., so that more people were able to come and see people who were living in care home settings, really understanding what a detrimental effect it was having on people's health and well-being when they couldn't remain in contact with their families. We took a lot of advice from our health colleagues at LYPFT around the care and support needs of people with dementia and how we could support them, particularly in accessing visiting. So just really an example that was of how we connected together in supporting care homes. We also had access to the Infection Control Fund, and that the various rounds of the Infection Control Fund was allocated to our care providers so that they could increase their staffing to help with the whole requirements around facilitating the visiting arrangements and the rigorous testing of people who were coming into the care home setting. I'm sure you will appreciate that this put an extra layer of responsibility and burden on care homes because they themselves were keen to allow visiting wherever possible, but also very mindful of not enabling any form of transmission of the virus, because we'd seen quite horrendous circumstances where a number of residents had become seriously ill or had passed away because they had contracted the virus. So really important to have connected with the care homes to support them in enabling the visiting to happen. We also put in place a bulletin, an information bulletin that went out to the care homes twice a week and then reduced to once a week, and now it's still available once a month. But that was giving information as soon as information was being made available in terms of guidance changing, and that was all sorts of guidance in terms of managing the pandemic, but also very specifically around visiting as well. So I have to be honest, it's really important to say how valuable we found our network with our third sector organisations, with Health Watch, with Carers Leeds, with a range of other third sector organisations, but also equally with our care homes in coming together and working together to promote the well-being of those people that were resident in care homes. And that, I think, has put us in really good stead going forward. We've built really strong relationships with our care providers in a very supportive way, always with the focus on those people that are resident and also their family and loved ones in the community. So I'll stop there. I know that some people have already provided updates from their healthcare setting perspective. Happy to take any questions.
Thank you very much, Caroline, and thank you for that update. I mean, all of us sat here today, we do know the hard times and difficult times with care homes. I mean, we were hearing on the TV, we were hearing from friends. It was just very, very heartbreaking. And there's nothing as heartbreaking, as painful, knowing, especially with elderly people who are unable to help themselves. If they're in a care home, there's a reason why they're there. And just knowing what happened, especially over the last 2.5 years, still, I mean, when I think about it, I still feel really, really sad. But to hear some of the interventions that were provided to our care homes, I would say thank you very much and well done. I know lots still needs doing, lots of answers we still have not been able to get. So today is about talking about those times and what we can do going forward. So it will be nice to actually hear from the care services themselves. I know on the agenda we have the Leeds Community Healthcare Trust first, but I would want to bring in Michelle, if that's okay. If Michelle can speak to us first, and then we'll go back to the hospital trust.
Thank you. I think it has been really, really difficult for the care homes. They're still not out of the woods, and I think we need to remember that. The testing restrictions have now been lifted for visitors, as I'm sure that you're all aware. However, that poses further challenges for the care homes in terms of still trying to keep COVID out of the care homes. Some visitors are asked if they wear face masks in communal areas. We have visitors that don't want to comply with that request. So it is still really, really difficult for the care homes. They're still trying to manage visitor numbers, because especially for those care homes where you've got smaller care homes that don't have large sort of entrance ways, it's really difficult. They don't want lots of people coming into the care homes all at the same time. So whilst they are trying to enable visiting to go ahead, it's not still, you can just turn up to the care home. We know with some of the care homes, they still are asking people to ring first and make sure it's okay. And then they've got to manage the care home if there is an outbreak as well within the care home. So things are still really difficult for the care homes, still getting changing guidance. And can I just say, big thanks to everybody that's been on the working group, because I think there's been a lot of really positive work come out of that working group. And certainly the bulletins that have been produced and sent round to the care homes have been really, really well received, especially when there's been changing guidance in those bulletins, because sometimes guidance was published on one day, 2 days later, you've got changes to that guidance. So it saved the care homes having to go sort of trawling through all the guidance on a daily basis when they knew that they would get the updates through from the City Council. So a big thank you for that. So care homes are trying to enable visiting. You know, they have gone through so much. They didn't like restricting visiting in the first place. They are trying to enable visiting to happen now. So, and hopefully as things progress, more and more people are getting back into the care homes to visit the loved ones.
Okay, thank you very much, Michelle. Can I now call on St. Gemma's Hospice? Heather, please.
Yeah, thank you for that. So I think we've been relatively lucky as a small organisation. We can make decisions and share those decisions really quite quickly and quite easily. And we have a very restricted number of bed bases with 20 beds available for our half of the city. So throughout the pandemic, we've been able to, we've met daily and weekly, and visiting has been talked about for the last 2.5 years, every single week. Because we know it's such an important part of palliative and end-of-life care for families in Leeds, and was often their part of their decision about whether they wanted to come into the as an inpatient into the hospice or not. We've really good communication across Leeds teaching hospitals and the community teams that we work with really closely to ensure that we met the needs of patients and their families as best we can. We also were able to secure a really good supply of PPE very early on in the pandemic, and then we worked together with the rest of the city around the citywide supply, which provided us with the opportunity to ask all families to wear PPE whilst they were coming into the organisation. So at no point did we have no visitors coming into the organisation. We were able to have some visitors at all times throughout the pandemic, and we are currently with open visiting. It's completely back to normal, despite the current state of our COVID levels in the city. Obviously, we tested as everyone else did. We all relatives tested, all family visitors tested until the restrictions were lifted on testing, and that is, as Michelle's just said, one of our challenges going forward about how we ensure there's security around COVID transmission when there's no testing regime in the system. But so I think we've been really lucky in this system that we've been able to maintain visiting throughout, but that's because of the size and the shape of our organisation.
Okay, thank you very much for that, Heather. I will now call on Sarah.
Thank you. I don't want to repeat some of the challenges and the approaches that colleagues have outlined, because there's lots of similarities. Just to share some of the specifics really from a mental health and learning disability provision point of view. Really, despite kind of working in challenging circumstances and national policy directives, avoiding blanket restrictions and blanket policies was important to us, because there's huge variability in terms of the 420 beds that we operate, from young people's services through to, I think as Caroline described, people with quite severe cognitive impairment. And a significant proportion of people that are in our inpatient wards are there under the Mental Health Act. So there's that whole additional complexity in terms of the legal framework, supporting people with their rights and not wanting to add to their mental health distress for them feeling isolated for long periods of time. So whilst in the early days visiting wasn't allowed on inpatient wards, trying to take a person-centred approach to using the grounds where that was possible for people to have access, and some of the other measures that has been described in terms of iPads, telephone contact and other means. And then as soon as the national restrictions were lifted, a bit like St Gemma's, we introduced and started with our older people's services initially to pilot and evaluate how that went, managed visiting so long as testing was done, and if people didn't have tests, then we provided those for people to come into the wards. Again, pre-booking so that we didn't have too many people in the ward environment at the same time, and that's what we maintained until the changes in the access to free tests, and that's no longer a requirement. We do still have small numbers of outbreaks, but again, that's taking a very individual response to only managing the outbreak and not having those blanket restrictions on any visiting. So now it is around visitors contacting the ward, making those arrangements either to come into the ward area, only if the service user can't go off the ward. Otherwise, those visits could take place elsewhere, or our service user can go on leave to visit with their family members. So yeah, I'll not say any more, because it might be that there are other specific questions that members have got relevant to our services. Thank you.
Thank you very much, Sarah. I will now ask Steph, if you think everything has been said and it's a repeat, I'm happy to move on to Health Watch, if that's okay.
I haven't got much to say really, because we just have one inpatient unit and it's a very small children unit. So visiting was never restricted in that unit.
Excellent. Okay. Thank you very much. Health Watch.
John, are you happy for me to speak?
Yes, please, Harriet.
Yeah, fine. So we did quite a bit of work during the pandemic to hear people's views that were living in care homes and their relatives, specifically around visiting. And I think one of the key things that came out of both reports that we did was the variation across care homes. So there's something like 140 care homes in Leeds. And there was just a really big variation in terms of how the guidance was being implemented. So Leeds City Council were doing a really good job of interpreting it and sending it out, but actually on the ground there was a big variation, and that was even sort of later on in the pandemic that was happening. And so of course then that will impact both residents and relatives' experience and sort of determine whether they have a good or bad experience. And so we heard that whole spectrum of people who were able to see their family and people who weren't. And I think that we can't forget the devastating impact that had on residents and their family members, both mentally and physically, actually. because families play such a kind of important advocacy role as well, you know, informal advocacy. I know this meeting is also looking at advocacy. So sort of moving on, we were part of the working group that was set up. And, you know, there was, you know, we met very regularly during the pandemic. I think at one point it was every couple of weeks, or it might have even been every week. And just because it was such an ever-changing situation, and just trying to kind of hear what was going on the ground, you know, we were feeding in, and as were carers Leeds, what we were hearing from people that, you know, family members that were using services. You know, maybe after this we could hear from Andrew, who actually sat on the working group as well, and Andrew's wife is in the care home. And again, the theme was the same, that in the working group we'd hear this kind of variation, both from how care homes were kind of catching up with the guidance, because it was changing so frequently that there was this lag, and some care homes were you know, able and had the resources to act quickly, and you know, even now that is the case. There's still variation around, you know, like Michelle said, that some people are booking, you know, taking bookings and expecting people to ring, whereas other people are managing to return pretty much to business as usual, and have this kind of much more open visiting, which, you know, helps people to feel like it's their home, essentially. So the working group actually stopped meeting quite recently, but the last thing that we did was put together some sort of key messages, really, that that we wanted the city to remember and to kind of take forward, I suppose, so that, you know, with a view to that, you know, those early days of the pandemic, those experiences that people had, that they never happen again. And so those messages have been shared with the chair. I mean, I'm happy to kind of very briefly run through them if that's helpful.
Yes, please.
Yeah. So the first one is to learn from the past 2 years, so that visiting restrictions are always proportionate and never happen again to the extent that they cause more harm than good. We want care homes to return to business as usual, where unrestricted visiting and family contact is seen as central to residents' well-being. It's seen as central to residents' well-being and sense of home. So that idea that this is people's home, and that we mustn't forget that, and all those things around having family contact when you want make it feel like home. Number 3 was just like I touched on before, but recognising that families are an absolutely integral part of a person's care. You know, they are their often reason to be alive still. You know, they are their link to the world. They are often their memory. They're their advocate. They're often very much a practical support. You know, they know that person like no other person does, and can support them, you know, in the best way. And that visit any future visiting restrictions, they just need to have that at the forefront. I think sometimes during the early days of the pandemic, the weight had shifted more over into infection control for understandable reasons, but it felt that in the very early days that value of family was not there. It was not recognised. Number 4 is to get the messaging from public health right as a city, especially going into winter with the risk of another wave or increasing numbers. So again, that sort of narrative, there was just a very strong narrative and focus on numbers and statistics, but that needs to be balanced with the importance of well-being and what we need to do on the other hand as well. And lastly, just around monitoring, really, and to ensure that monitoring around visiting is maintained, and to ensure that care homes are complying with current guidance. And that just comes back to the variation thing, that some care homes have done well and some haven't done so well. And how do we know what is happening in those 140 care homes?
Thank you very much, Harriet. Sorry, I had a blank moment there. Thank you very much for that. And just being there and being a big brother for us, honestly, has really helped us know lots of the experiences that a lot of people have faced over the pandemic and ordeal they went through with trying to visit loved ones. I can't tell you how difficult it has been, but when when you hear from those people who are the ones feeling the brunt of this, you will just have tears in your eyes. So thank you for putting that to us. I do know you have a relative representative here, and I really would like to hear from you if that's okay. I know Harriet has said a lot, but because of the work that you do, you are directly speaking with the people that we're having this board for, because at the end of the day, as scrutiny advisors and as people from a board of scrutiny, for me, the message and what we do every day is for that common man that's out there that they do not have the privilege to sit around the table like we have. So I am very, very interested in hearing experiences firsthand from people on the experiences they had with the care home. So I believe, Andrew, you will have some information for us. So over to you.
Yes, I'm afraid I haven't really prepared anything to say specifically, but and Harriet has provided a very good summary of the evolution of visiting through COVID. I can't describe how awful it was on March the 22nd, 2 years ago, when I was wrenched apart from my wife, not knowing whether I would ever see her again. On the day that lockdown started, visiting was closed absolutely. Happily, she is still with us, and I have seen her, and I'm visiting her regularly. I acknowledge that the policies were largely driven by central guidance from NHSE and Department of Health. But as Harriet has already pointed out, everything was directed at suppressing COVID at the expense of all other considerations. And some of the guidance that emerged there was frankly wrong and misguided. And little or no consideration was given to the unintended consequences of the measures that were imposed. And again, Harriet has emphasised the, basically social deprivation of all those people. You've highlighted some of the things that were introduced, such as video calls and iPads and so forth, so that families could keep in touch, and window visits. If the resident is on an upper floor, window visits are impossible. And as is the case for my wife, the use of a telephone or an iPad to communicate was hopeless. The level of her dementia made that frankly impossible. Happily, visiting has slowly been reintroduced, and let's hope that's what we went through then is history. It can't happen like that again from at the outset. And so many of the measures, I was invited to join the Health Watch group that sat, and I hope I've made some valid contributions to that. And I think that the way that things have moved has been constructive. And I think that's what I have to say. We can't do it the way we did it first time round again.
Absolutely, Andrew. Thank you very much. We can't do it the way we did it previously, and hopefully this never happens. And pleased to hear that your wife is still with us, okay? So let's take comfort from that, and you look after her for us, wouldn't you?
Of course I would.
Excellent, thank you.
I would say one other thing, which there's a sort of grading of family visiting. So if I describe, when I had my wife at home, I'm now retired, so I wasn't going to work during the week, but I would pursue interests that she wasn't involved in for perhaps, let's say, at a guess, 12 hours a week. And the rest of the week I would spend in her company. I was her company. And for that matter, she had some interests of her own.
Yeah.
There are 168 hours in a week, so that reduces it to 150 something that we were apart. When she went into a care home, those numbers are reversed, and I'm her nearest, companion.
Yeah.
So I was perhaps visiting her most days of the week for 3 or 4 hours, maybe 20 hours a week. And the other 140 hours a week, she was deprived. That's slightly different from, say, a family member who's a son or a daughter who might visit their parents, mother, who lives independently a couple of times a week maybe, and then they go into a care home and they can continue to visit a couple of times a week. But for me, it was an absolute transformation from nothing, from 20 hours a week to nothing. And there are grades of visitors, if you like. I don't know if I've put that point across very well. It was painful.
Yeah. Yeah, thank you, Andrew, for sharing that experience with us. And yeah, we do understand that. Whilst we have all of you here, especially the executives, can I ask if you have any input into any inquiry about the national, if you have any input into the national inquiry handling of the pandemic, especially with care homes? Can I ask if any one of you has got any input with that? None of you. Is there any plans to do that? To ask for an inquiry into what happened?
I think that there should be, and we should do that. I'm not sure about the terms of terms of reference for that inquiry yet. But
okay.
Maybe Sarah can offer something.
Right, Sarah?
Yeah, so the terms of reference for the National COVID inquiry have been agreed, and they are very broad, and we've all just been advised to not dispose or destroy any records, and that as that inquiry gets underway, then the inquiry panel will seek evidence. But my understanding is it will include the whole of the response to and support and guidance to the care homes, as well as the NHS response, as well as I was recently copied into a letter, I think it's from this region, requesting that it also included the approach to establishing the Nightingale hospitals too. So it is very, very comprehensive.
Okay, thank you for that, Sarah. Can I ask Victoria, thank you very much for joining us. Would you like to chip in from all you've heard? Is there anything you would like to add on this agenda item?
Thank you, Chair. Well, partly on the last question to echo Sarah's response. So we're very much ready for any contribution to the national inquiry. We've obviously been all along kind of making sure that we're very clear about how we have kept a strong record of all that local action throughout the pandemic period. We haven't been asked to, we haven't been called as a Leeds system to contribute yet, but that may well come, or it may well be we contribute to a regional response and feed in that way. We just don't know, but we're very prepared and ready for that. I think my only two overall comments on everything that colleagues have described is to fully, as Director of Public Health, to fully support and endorse all the efforts that we've gone to as a local system within the restraints of national guidance and within a very dynamic situation. To do everything we possibly can to balance the risks to health in a broader sense. So you know, very, very clearly that it was I mean, what reflecting back with colleagues, I think one of the most challenging times of the pandemic was when we were seeing so many care home deaths. You know, we cannot under kind of state the seriousness of the risk to our most vulnerable citizens, you know, at that point in the pandemic. So clearly things were very challenging, but at every opportunity I know that the the public health team, infection control team, and all colleagues did everything we could locally to support people's wider health and well-being, and would still keep that approach to today, and that applies to other settings, whether it's closing schools or any kind of reasonable balance that we could achieve. So I do think I agree with Harriet's comment around we really need to learn the lessons nationally around that balance, because I think with hindsight we would want to do things differently next time, but given the dynamic position through the pandemic, there was a very live response, which we were all doing everything we could to balance well. I think that in terms of ongoing risk, and colleagues have commented around ongoing challenges, clearly the vaccination has been a game changer in this, in terms of that balance of risk and the protection people have from vaccination. So we know we've got, I think the last number of infections in care homes was, we've got 23 care homes with cases, but we don't have anybody severely ill at the moment, which is very good news. So I think that it's just a very different scenario with the protection of the vaccine going forward, managing that risk as opposed to people's wider health and well-being emotionally and socially. Thankfully, we're in a much stronger position now. So I think that we need to take all of that into account. And my final point is, Steph's very involved in heading up the service, but one of the things that I know I feel very proud of, and a lot of colleagues feel very proud of, is that because we went into the pandemic with a very strong infection prevention and control service, and through the pandemic we further strengthened the capacity of that service within the city. It meant that we were able to provide really intensive and very specific support by care home or other institution in the way that other places wouldn't have been able to, because of the quality of that team, and also the capacity it gave us across the city. So I think in terms of our local learning, and being very mindful of how we keep ourselves safe for the future, one of the really important things I think it's useful to recognise is that we've intentionally made sure that we protect that really valuable team and that really valuable function, which sits in Leeds Community Health Trust and is commissioned by the council, because without it we would be in a much worse place. And I think we need to sort of recognise our local strengths and how we build on that going forward. So I just wanted to recognise all the great work of those local teams. Thanks, Chair.
Thank you very much, Victoria. Excellent as always. And I love the futuristic plans as well. As Andrew said, never again. We cannot turn back the hands of times, that's for sure. But obviously going forward, ensure that, we put things in place for not just for what has happened, but for any other time in our lives where our elderly and anybody in care homes or in hospitals are duly safeguarded and protected. I do know that one of our board members had a direct experience during COVID, because obviously I did receive an email and that was escalated to the Chief Executive of the hospital. Councillor Iqbal, are you there? Would you like 2 minutes, just share with us what you went through and what feedback you got back from the hospital with the experience from one of your relatives, please?
Yeah, hi. The problem is that we've got, there's been arrangement with coroners to prioritise release, to prioritise post-mortems and sort the paper out.
Sorry, Councillor Iqbal. I'm making reference to visiting. So we're going to stick to the agenda.
Okay,
So
sorry.
remember there was a complaint that came through to our office. So we just want to stick to the agenda. We do have the coroners on a completely different agenda. So
Yeah,
we'll get
okay,
to that.
sorry, forgive me. To be honest, it's not loud enough and I'm hearing part of the conversation, but with the fan on as well. Yeah, the visiting issue is that there's the language issue. There's certain community elderly, especially elderly members, who cannot communicate and explain to nurses what they need, what their requirements are, and sometimes as simple as going to the toilet. And it's, I got a complaint from one of the constituents, and the daughter was very worried because the mum could not explain anything, and she started deteriorating health-wise until her daughter, who works for NHS and was very forceful in a polite way to argue and present the case. Look, my mum's got a problem. She needs explaining. She needs comfort. And you, unfortunately, because of the language barrier, because of the cultural barriers, you will not be able to understand her. And thankfully, the staff agreed. And we have the greatest deal of respect for the staff and the difficulties they're going through. But you have to balance each case for its own merits. And as a result, she was able to go there. And it was as simple as the lady not being able to explain that she wants to go to the toilet, she needs water, and things changed. And it was very comforting and reassuring. So the concern was to, we need to find a balance rather than just a straightforward policy of not allowing anybody. Where there's elderly people, they can't speak, there's a huge cultural difference, understanding. I think there needs to be some better understanding and practice.
Absolutely, better understanding and practice. Thank you very much, Councillor Iqbal, for sharing that with us.
Yeah.
Thank you. Councillor Hatbrook.
Yeah, just quickly, to pick up, I think, on what Mr. Patterson was saying towards the end. I was a sort of an assistant carer for my elderly mum who gets residential care in her own home. And during the start of the pandemic, just as we all were, we were all learning what this new disease was and what its implications were and its severity. And, it felt a very uncertain period in the early part of 2020. And I effectively put her into self-quarantine that I stayed away until kind of, later in the summer. And then she went into hospital after a fall in November and came down with COVID a week later, which kind of made me think that I wish I'd kind of stuck her in Wetherspoons to catch it in the first wave and get it over and done with. But I'm always struck by something, to those who say we shouldn't, we overreacted, we underreacted. I think there are two things. One, I think there needs to be a hierarchy of visitors, Mr. Patterson and others who have a long history of close. I think we need to find some way of having tiered access to people if there is another pandemic or some a similar event. And the other thing is, I think we need to kind of just be very mindful that we've all learned a lot during this, particularly during 2020. And what we're all sitting on here is an awful lot of hindsight, and we all know we would do things very, very differently.
Yeah. Thank you very much, Councillor Hatbrook. Thanks. Councillor Arif, thanks for joining us and good to see you.
Chair, apologies, my video's off. My internet was playing up, so I froze at one point. So it seems to be okay since I've taken my video off. So yeah, my name's Councillor Arif. I'm the Exec Member for Public Health and Active Lifestyles. A couple of, I suppose, observations. Following on from what Councillor Iqbal's also said, I think I had during the pandemic as elected members, I had a gut-wrenching conversation with a son who was looking after his mum of 90 years. He was the carer. Wasn't able to see mum, and it was just a really, really difficult time. And I think there ought to be, in certain circumstances, some flexibility. But as Councillor Hatbrook has said, that is a whole thing. What I did want to do was just share my experience, actually, if I may, on the back of what Rob said earlier, and Joe. My mum was admitted to hospital a couple of weeks ago. Mum's a renal transplant patient. She doesn't communicate in English very well. On day one of her being admitted, we missed the conversation with the consultant. There was some medication that had to be altered. And because we missed that conversation, I very kindly asked, and this was not during visiting times, I asked if it was possible if I could be there the following day and if that exception could be made. And actually, it was brilliant because what the nurse said to me was, look, every case is different and, we're willing to show that flexibility. And it made such a wonderful difference to us because it meant I was able to communicate with the consultant, have the conversation we need to have as a family to discuss mum's plan. And I just really, really want to thank LTHT for that approach. It really made a massive difference in terms of our anxiety and what was happening. So please continue with that approach where in certain circumstances, there will be instances where families may need to be there sooner. And I'm so grateful, honestly, for that. It just made a massive difference to us. So just a big thank you really to Jo and her team for helping with that.
Thank you very much, Councillor Arif, for sharing your experience. And that's very positive and comforting. For those listening from outside, LTHT stands for Leeds Teaching Hospital Trust. So thank you very much for sharing that with us, Councillor Arif. Councillor Anderson, and we're taking questions now as well. And just, if you've got any comments, please do not hesitate to put your hands up. I can see you all on my screen and I'll call you. Thanks.
Thank you, Chair. I just wanted to say thank you to Mr. Patterson for coming to the board today. It's really important that we hear from people who have had a lived experience. So I really do appreciate that. And I am very sorry to hear that he had, such an awful time not being able to see his wife. I am concerned to hear that we do still have restrictions in place in some care settings. And I do think it's so important now that we actually balance the health benefits of people being able to have visitors against the potential for catching COVID, because we know, and Victoria's said this, older people now in the main have had 4, sometimes 5 jabs, and they are not getting seriously ill with COVID. It's not as bad as colds or even flu. We've never had a vaccine for the common cold, and that can lead to all sorts of problems. So we need to balance this out a bit better. And I would like assurance that we are working with all our care settings to get back to some kind of normality, to allow, it is far more important, I think, now that people can see their loved ones when they want to, and not be tied up in various restrictions. Can I just ask Mr. Patterson if he's willing to share with us, have you noticed a deterioration in your wife over the last 2 or 3 years? I know that with dementia, that's normal, and it's maybe difficult for you to say, but do you think that her not having you there led to a more deterioration than you would normally have expected?
Obviously, I've reflected on that myself, and as you say, dementia is a slowly progressive disease, so some sort of deterioration would be expected over that time course. What I can tell you is that in the first 2 months of lockdown, she just stopped eating and drinking, and she lost 1/2 stone in weight. And it's impossible for me to accept that that was anything other than the fact that she had been cut off from the rest of the world.
Yeah. I mean, I have got a few friends whose wives have suffered with dementia, and they've been looking after them, in their own homes, and they've had trouble with people not wanting to eat and drink, and it has led to a vast deterioration. But thank you for sharing that with us. Thank you for coming today.
Thank you very much, which obviously is one of the reasons why we have this on the agenda today, because we do know the impact of the national policies and guidelines that were given to nursing homes and care homes, and the impact it had on residents in the care homes as well as their families. And we're really hoping that we never, ever see this again. So, okay, I'll call on Dr. Bill and then Councillor Harrington.
Thank you very much, Chair. I've got 2 questions, but can I first of all reiterate your thanks to all those people who have been providing care over the past 2.5 years, whether that's in the NHS, in the care home sector, in the hospices, in the voluntary sector. I think that there are many people who deserve our thanks for all the care they delivered to the community in Leeds. The first question is for either or Caroline or Michelle. bearing in mind that in the care home sector in particular, there are numerous staff shortages and a large turnover of staff. So could you tell us what ongoing training there is for the managers and the staff in care homes to ensure that they are all familiar with the latest advice and recommendations? And the second question, I may be accused of being too political, but I'm talking to a load of politicians, so I will go ahead. My understanding is that there are lots of homes which were set up by individuals or small organizations who actually wanted to do something to help some of the most vulnerable people in our society. And they set up a single or sometimes a small group of care homes providing that service. And, you know, all part of their elbow, they're running small businesses and they deserve to make a fair return on their investment. But my understanding is that there are other care homes which are part of large chains set up by financial institutions. I conclude from that basically they weren't in it for the service they were providing. They were in it for a quick buck from what was an expanding sector of provision. So my question is, and I guess it's probably to Caroline, is there any evidence that the way in which small care homes or small groups of care homes behave differently from the larger institutions?
Okay, thank you, Dr. Bill. Caroline, are you happy to respond, please?
Absolutely. Just checking that you can hear me. Can you hear me okay?
Loud and clear, thank you.
Okay, so in relation to the first question, the training that is available to care homes, that has been available to care homes around managing the pandemic, has been run by our infection prevention control colleagues at LCH. That support is still readily available, bearing in mind and recognising that there are workforce challenges and staff turnover. And also actually to add that a lot of care homes have lost their registered managers. You know, the managers have just had more than enough and have decided that's it. You know, a lot of them are in their latter years of their careers. So, and for a time, especially after the first year of the pandemic, we saw care homes losing their registered managers and all the leadership that goes with that. So yes, there is still a massive recruitment, retention, staff turnover, instability in our care homes. This is not unique to Leeds. It's a national issue, an issue that we're constantly raising with the Department of Health and Social Care and also NHS England. So that continues. Regardless of that, the support that was available to care homes during the course of the last 2.5 years continues. And I'm sure Steph will tell you that the IPC team continue to do an absolutely fantastic job in supporting care homes. That aside, we also have the We Care Academy, we have the Leeds Health and Care Academy across our system, and that also offers a range of training and support, not just related to infection management and control, but a whole range of things that support our independent sector workforce. So that will continue. I don't know if Michelle wants to come in on that particular question. I'm happy to move on to the second question if Michelle doesn't have anything to add.
I think the only thing I would add, Caroline, as well, is around the support that's been available through Skills for Care during the pandemic, because they've put quite a lot of information out there. Training's been available to registered managers and other staff. And I think it's also safe to say a lot of the training provision has been moved from sort of classroom-based training to Zoom or Microsoft Teams, just to ensure that that training could still be carried out and that staff could still keep up to date with the most recent training. And it is something, of course, that the regulators have been looking at anyway and do continue to look at. Thank you.
So in terms of your second question then, is there a difference between the way in which larger national care homes are organised and run compared to smaller homes. Often the difference is in relation to infrastructure support. So the large national organisations will have their own significant HR departments, policy departments. They set their own guidance for their staff. That isn't the case often for the smaller homes, and you'll find that the owner is also the registered manager. The registered manager is also the finance director, the HR director, and they assume the responsibilities at various levels and for various aspects of running the home. Apart from that, there is a huge amount of difference in terms of training, recruitment, retention. In fact, what we find often is the smaller homes are able to retain their staff well. They offer a lot of support. They focus on local staff that live nearby, who have been with the organisation for years and years. So in some instances, their staff turnover is probably lower than for some of the larger organisations. But in reality, we need a care home capacity. There are pros and cons with smaller organisations relative to larger organisations. The larger organisations, national organisations, are able to offer us more capacity usually because they own large purpose-built buildings compared to the smaller homes. There is room in the market for both. I'm not going to answer the element of your question that is around their finances and how their finances work, because I think that is quite a political question. Obviously, they're all independent businesses in the main. Some are charitable organisations, but in the main, they're profit-making organisations, and there's an element of profit that is built into their business setup. You expect that whether it's a small local home or it's a national home. I hope that gives some indication in terms of answering your question, Dr. Beale.
Thank you very much, Caroline. You happy with that, Dr. Beale? And we could pick up later if that's all right, because we've got a few more hands up and we need to move on to the next agenda.
Yes, I was happy. I wasn't asking Caroline what her view about the financial implications were. That was my impression. I may be wrong, but that was the impression I read from what I have from what I read. Thanks very much, Caroline.
Thank you, Dr. Beale. Right, I'll take the questions in twos and then we get a response and then come back because we've got 4 hands up. It'll be Councillor Harrington and then Councillor Farley. Over to you.
Thank you, Chair. I agree totally with almost everything that Dr. Beale said about thanking the staff that have been working through this horrendous time. It's been awful. And I know from the 6 care homes plus the 3 or 4 assisted living places that are in my ward alone, how difficult staff retention has been. One of the concerns that I have is that CQC don't appear to have been doing very much during the pandemic. I'd stand to be corrected if somebody's going to leap in and say they've been doing loads, but I don't necessarily feel that they have. So I'm kind of wondering when they're going to start again visiting care homes, because of those 6 care homes that I mentioned, they have all been operating totally differently as far as visitors are allowed in or whatever. They've been all operating totally differently. There've been guidelines and they've paid some kind of adherence to that. But if you went from one to the other, there was quite a lot of things that were different. And I'm concerned that CQC are going to have an awful lot of catching up to do to see actually what's been happening in those care homes during those 2 years, and are we ready for the implication that several of those care homes are going to be reduced on their levels and they will be going from good to requires improvement, and what support mechanism will we then have as a local authority to support them to bring them up to a reasonable standard? Thank you.
Thank you very much, Councillor Harrington. Very good question. Councillor Farley.
Thank you, Chair. Yeah, I mean, I'd just like to echo my colleagues in passing on kind of passing on my thanks and thanks of, I'm sure, many people right across the city to our health and care staff, the incredible job that they've done over the past 2 years. I think it is important to remember that obviously COVID is still with us. It hasn't magically gone away with the restrictions. And with this in mind, given obviously the current rate of COVID infections and the potential of the virus to mutate and obviously become more virulent, more dangerous, and the potential threat of it being vaccine evasive. I suppose my question would be is for both our health and care providers, is there the potential for visitors being restricted in the future outside of national guidance? And with your indulgence, Chair, quite specifically for our NHS providers, obviously as we go into winter, we may be expecting more cases of COVID. Obviously, we've got a different testing regime than what we had last winter. But what will be, what measures are being taken to stop the spread of COVID from visitors within both acute and community settings, and and mental health settings, would we will this impact on patient flow? Will we be looking at greater restrictions going back into hospital environments in terms of and then obviously what impact will that mean for delayed discharge and the impact on other patients? If that's clear.
Thank you, Councillor Farley. Okay, who would like to start first? So we've got Councillor Harrington's question on CQC. Yes, Caroline, over to you.
Thank you. Yes, in terms of the CQC inspections, they did stop, of course, during the couple of years of the pandemic. However, they have reinstated their inspections, but it is very reactive. They are targeting their inspections into those care homes that have previously been rated as requires improvement, or in the very small number where they have identified that they are inadequate rated. So, and also in response to either complaints, concerns, or safeguarding inquiries. So where we as a local authority or other health and care people have been going into care homes, where family and carers have been going into care homes and have raised concerns about quality, they have been flagged up with the CQC, and that's when the CQC inspectors have gone out and visited. So they are absolutely removing themselves from doing their annual visiting or 2 yearly visiting that they were doing pre-COVID, and they are focusing their regime and their activity in relation to those care homes that have been identified as having some difficulties and some problems, wherever those concerns are raised. At the moment, the CQC is out to consult with the public around changing their previous inspection regime. They're consulting with care homes as well about that. So to be honest with you, we don't foresee them going back to inspecting in the way that they were doing pre-COVID. So where care homes have been identified as a good rating or an outstanding rating, there might well be years before they go back and inspect, and will really only target where there are known concerns and identified concerns. So I think that's going to be the case going forward, Councillor Harrington.
Okay, thank you. There was questions from Councillor Farley. And that's the care home visiting with obviously the current rise in cases. Who's able to answer that, please?
I don't know whether that was in relation specifically to care homes or more so in terms of healthcare settings.
Both, I believe.
Yeah, so certainly I can respond in terms of care home settings, and that is we will absolutely abide by the guidance that is issued by NHSC, by UK Health Security Agency, and we will enforce and implement that guidance. We have, as Victoria said, I mean, only last week there were 33 care homes in Leeds where there was a COVID outbreak. Now, fortunately, not all of those care homes had to close to admissions. So even people being discharged from hospital, the care homes were able to accept people. Some were closed if the numbers of residents affected was high. It didn't stop visiting. The care homes were still enabling visiting, and that was with all the precautions that are in place around testing, around good use of PPE. So as Victoria has already explained, we're really fortunate at the moment that there's been a really good level of uptake of vaccinations and boosters by residents, and that is reducing the risk to residents. I understand, Councillor Farley, that you were saying, well, you know, if the different strains and variations become resistant to the boosters and to the vaccinations, then what will the situation be? And all I can say at this stage is that we will have to be minded by national guidance.
Okay, thank you very much. I've seen Rob and Victoria. Is that in response to the question or something? Yeah, okay, Rob and then Victoria, please.
Mr. Councillor Farley, I think you asked about the potential for more restrictions and potentially to be outside of national guidance. I guess to reiterate what Caroline says, we would continue to follow national guidance. Now, throughout the pandemic, we followed national guidance and it also encouraged staff discretion and judgment. And I guess as the pandemic's progressed, Joe could probably say better than me, but some more confidence amongst staff to take some judgment calls. And actually picking up what Councillor Arif has said, that's been supported by and been appreciative of councillors, some on this board, raising issues to us as a trust, and then us being able to learn from cases that have been escalated to us. So appreciate that. Also, on your point, Councillor Farley, so at the moment today we've got over 250 COVID positive patients in our wards. So we're experiencing a surge in COVID patients. We continue to have some restrictions on our visiting, less than we did at other points and less than we did at other points when we had so many COVID patients in at previous points in the pandemic. That is obviously having an impact on the flow on our hospital occupancy and therefore the timeliness of care that we can provide to people, because wherever possible we work to keep those COVID positive patients together so as not to spread COVID throughout the hospital as much as possible. But Joe may want to add some detail on that.
Thanks, Rob. I don't think think you've said most of it there. I think the thing there for me is the confidence and the staff confidence. Their confidence has grown in risk assessing some of our visiting restrictions. However, now obviously we're back to visiting as we were before, but like you say, for the patients that we do have that are positive, we are still risk assessing for those visitors, for those patients.
Okay, thank you very much. I'll bring in Victoria now.
Thank you, Chair. I'm really mindful of time, so I'll keep it brief and just add to the comments from Rob and Caroline. Just two things. Councillor Farley raised again around the point around local new restrictions and where we might not follow national guidance. We wouldn't we wouldn't not follow national guidance and bring in any local restrictions and haven't done right through the pandemic. So we would absolutely stick to that approach, Councillor. I think we're also really close to national colleagues on the things that would trigger any change to that national guidance. So there's some red flags in the system that they look to. So this is Chris Whitty and his team would look to, which would make them worried enough to change the national guidance. So one of them, as you quite rightly say, is because we keep looking at the variants of concern, and the surveillance there around checking that they're not evading the vaccine. Now, if there was strong evidence that we did have a variant of concern that was evading the vaccine, that would be a red flag to consider changing national guidelines. Another red flag would be, Rob's mentioned we do have around 250 people in hospital with COVID at the moment, but predominantly they're people with COVID, not primarily because of COVID and being severely ill because of COVID. But if that pattern started to change and people were severely ill primarily with COVID, that would be another red flag to change national restrictions. So we're really close to that kind of surveillance of those things that the system's most worried about, but we wouldn't make local decisions outside of any of that. We would always go with the national judgment. So that's one thing. And then secondly, just briefly, in terms of future approaches and the change in risk, I'm sure you're all aware we're now in this period of life that we're calling living with COVID, which really reflects the fact that COVID now isn't what COVID was at the height of pandemic before we had the vaccine as the strongest line of defence. So the big messages that we will continue to get out there to keep our citizens as safe as possible is that everyone needs to take up the vaccine when it's offered, particularly those people who are being offered boosters now to absolutely take that, because they are proving to be the most effective defence. It's not too late for people who've not even had a first vaccine to come forward and get it. So the evergreen offer will be there right through the autumn and winter. And then finally, because we don't have community testing anymore, the whole approach of people treating COVID as a respiratory illness, in the way that if they're coughing and sneezing with anything else, we wouldn't want them to go to school or work or visit relatives in a hospital or care home. So it's very much around sort of sensible, sort of basic public health advice to hand wash and just show that common sense, really, away from the really strict regimes of restrictions and testing that we've had in the past. So I think it's just getting people used to making those judgment calls. Now we're in that different phase. Thanks, Chair.
Thank you very much, Victoria. Thanks for those contributions. Okay, Councillor Taylor and then Councillor Kija. Sorry for keeping you waiting.
Thank you, Chair. I have no questions for these amazing people. I just want to thank each and every one of them, listening to Harriet and Andrew. But for the work what the care home did over the pandemic is just gratitude to these people. And I'm grateful. And also Victoria, if it wasn't people like Victoria, I'm only speaking on Leeds at the moment, we would be doomed, because the health secretary at the time and our so-called outgoing prime minister, they did not think for one moment of the elderly in care home. They just expect the prime minister. He have an elderly father and he did not think. He should have said, thank God my dad is in this age and he's in good health. But the elderly who was in the care home, they was our generation and brought us to where we are today. And I just have gratitude for the care home. Thank you, Harriet, and there's a can't think of the team. And Andrew, thank you. I was very surprised listening to Councillor Anderson asking Andrew, did he notice his wife deteriorating? I don't know if she wants to blame it. This is what happened to dementia people. 1 minute they are with us and the next second they're not with us. And to lock them away in the care home, that was totally, totally wrong. you know, if the care home staff wasn't there, who would these people see? Because we know dementia live in the past, and it's the people and the things from the past that benefit them more. So I just want to thank you all again, and thank you, Victoria, because it's people like you and across the city, not the government, that bring us back to where we are. And they're talking about it get us out of the pandemic. It did not get us out of the pandemic. The good Lord listened to our prayer and sorry for the people and ease the pandemic. But we just need to be more careful. Thank you.
Thank you very much, Councillor Taylor. Councillor Kidger.
Hi, I've listened to all of what you've said. My experience goes back to the beginning of the COVID. I lost a brother in a care home in Leeds area at the beginning of COVID, April 20. And at that time, we weren't aware of what was, well, we did know, but, you know, I mean, they said on the death certificate, they said that my brother died of COVID. He had dementia. He'd lost his mobility, and I just think personally he'd given up, you know, it was his time to go kind of thing. But the staff in this care home was absolutely unbelievable. Yes, they said we couldn't go in. Then at the end, when it was, you know, the end was near, we could, but we'd have to be gowned up and everything. I was asked if I wanted him to go to hospital, and as being his power of attorney and everything, I said no, I thought it was safer there. But this care home was absolutely unbelievable. And, you know, a few meetings ago, Kath Ross said, and it's so true, the NHS, as fantastic as they are, have always got a backup plan. But she found that people were leaving the care homes because they can earn more working a till at Morrison's or at the supermarkets. Now, when I lost my brother, my brother were in there, 3 years, and I know that those staff members felt the bereavement as much as we family did, you know, and this is where they are so fantastic at what they do. Now, I know, and I'm not going to say what care home it was, and I know there was something in the media about somebody not being allowed to visit and blah, blah, blah. And then I've just recently been drawn, well, in fact, it was a friend who sent me the clipping out of the paper that this care home, the CQC has been in and rated it not very good. And I'm just absolutely appalled at that, because to me, the care were fantastic. And I do think through the media, this particular case of this particular person not being allowed in to the home has blown up, and it's led to the CQC maybe branding them that they weren't right. Do you understand what I'm saying? And I just think, you know, it's such a shame that such caring people are getting and it is true, the carers, you know, they've done so much through all this pandemic, and we've all been blind to what's gone on, you know, not known. It's hit us like you know, like a bolt out of lightning kind of thing. But I do think the care homes, you know, we clapped for the NHS, but, and I'm not knocking that, but I don't think there's been enough done for the carers. And I just wanted to share that with you. You know, it was a very upsetting time for me and my family, but I will be eternally grateful to those carers. You know, and I do think it's sad that they're probably on basic money for what they do. Thank you.
Thank you very much, Councillor Kidger. And on behalf of the board, accept our sincere sympathy on the loss of your brother. We pray his soul continue to rest in peace. Yes, you know, like so many others, you know, that have lost dear ones, we will carry this for a very long time, most of it for as long as we live. And I believe we're sat around this table today, I'm saying table, not literally, but you understand what I mean, to make sure that what happened in the past, which we can't change, doesn't happen in the future. You know, that even if we lose our family, or if we're going to lose anyone, we don't lose them in the way that we lost them over the last 2.5 years, and hoping that, you know, the government listens to people. And that's why we're here, so that the ordinary man on the streets, people who have lived experiences like yourself, come here and tell us what's going on, and we can relay that to people who make decisions about our everyday lives. So really, really sorry to hear that, Councillor Kijia, and we pray for God's comfort for you. In terms of getting into the CQ, I'm not, I don't think we need to get into that because we do not know why they got the rating that they got.
Yeah.
So
yeah, I agree.
we can leave that outside of that now. But okay, I'll tell you what we're going to do. I will give us a 3 minutes break, if that's okay, before we move on to our next agenda. I've become a bit emotional and I'll just like to take a break myself. So if you don't mind, 3 minutes, please, get some water, and we will be back to continue on maternal health provision in Leeds. Thank you all for all your contributions. Thank you. Okay.
Chair.
Excellent. Thank you all and welcome back. Hope you were able to stretch your legs and have some water. Right, agenda item number 4 is maternal health provision in Leeds. Stephen, would you like to make the introduction, please?
Thank you, Chair. So this item is to provide members with a brief update on details that members considered previously in the previous municipal year. It's to provide an update on the Leeds maternity strategy work, the current position around Leeds fertility IV service, and the implications of the Ockenden review findings, and how any recommendations have been taken forward across the local maternity system in Leeds. So there's some specific details in relation to the Ockenden review attached to the paper. So members will have seen that, and the report that went to the Leeds board, the Leeds Teaching Hospital Trust board, and the response that's been made in relation to those recommendations. And we've got a number of colleagues from Leeds Teaching Hospital Trust and also from the Integrated Care Board in Leeds in relation to commissioning arrangements present at the meeting to be able to update members on progress on the other items, Chair.
Excellent. Thank you very much, Stephen. I was muted. Right. Okay. Thank you for all the partners who have joined us this afternoon. And I would like you to just kindly introduce yourself. It's the last item in terms of those who have been invited to speak. And I'll start with Councillor Arif, please.
Hi, Chair. Yes, it's Councillor Salma Arif. I'm the Exec Member for Public Health and Active Lifestyles.
Thanks for joining us as always. Claire, you here?
I am, yes. To introduce myself, I'm Claire Goodman. I'm the General Manager for Women's Services at Leeds Teaching Hospitals.
Thank you for coming. Dr. Everett?
Hello again, correct item this time. I'm Tom Everett. I'm the lead clinician for maternity services and a consultant obstetrician.
Thank you. Because of you're a doctor, we'll allow you to introduce yourself twice. That's what you get. Thank you. Okay, Rebecca. Head of Midwifery, is Rebecca here?
Oh, sorry, no, unfortunately she's having to be on the wards because of the extreme heat. She's actually covering people's breaks so they can make sure they get their water.
Bless her. Okay. No
we've also brought along, I hope you don't mind, two colleagues from the ICB for the maternity strategy update, Emily Griffiths and Liz Wigley.
Yeah, got them on my list. If they can introduce themselves, please. Thank you.
Thank you, Claire. Thank you, Chair. My name is Emily. I'm the Associate Director of Pathway Integration for NHS Integrated Care Board in Leeds, very recently the Clinical Commissioning Group for Leeds.
Fabulous, thanks.
My name is Liz Wigley. I'm a Senior Pathway Integration Manager for the ICB in Leeds with responsibility for some of children's and maternity healthcare.
Thank you very much. And do you want to tell us what ICB stands for, please?
Sorry, so that's the Integrated Care Board.
Excellent. Thank you all very much. Okay, who's starting, Claire? Is it yourself?
So our colleagues from the ICB are going to start with the maternity strategy, and then Tom and I may heckle as we go along. They've got a few slides. Then I'm going to pick up the fertility. I've got a couple of slides around fertility, and then Tom is going to do the Ockenden report, and we've got some slides for that as well.
Excellent. Right, over to you.
Okay, I'm just going to try and share my screen a second, but I'm not used to it. Oh, that's showing is disabled, I think.
Stephen, are we able to give them screen rights, please?
I wasn't aware we're having presentations actually delivered at the board, Chair.
That's no problem. We can just talk without the presentation.
Yeah, we're very intelligent. We'll get it. Just go on.
Okay, well, I'll make a start. The committee will be aware of some of the changes that we have been implementing across health and care in Leeds over the last few months. I'm sure you've had multiple presentations on the slightly different approach that we are trying to take post-COVID to the way we govern health and care. And the crux of that is to join together health and care in a partnership across the city, taking a population health management approach. So that means rather than looking at individual services and considering how we are doing for people during the timeframe within which they're using our services and focusing on those experiences, but perhaps not seeing beyond that in that person's life journey. So what happens when they leave? What happens before they come to us? We are trying to take a life journey and a think family approach. So really working to understand people's lives and how the wider determinants of health impact on their health outcomes, and to also understand the roles of other partners in the system and how we can best work together to use our collective resource to deliver the best outcomes for the city. So within that, maternity is very well placed for this agenda. We have actually had a partnership forum that's been guiding the delivery of the maternity strategy for a number of years in the city, and the committee has received previous updates on that. But the consolidation of this approach in the city means we now have a number of other boards related to other aspects of healthcare delivery that can support and work with the maternity strategy group to take that forwards. So Liz will talk you through a couple of high-level updates on the work streams that sit within the maternity strategy. We've not lost those during this update, but we are refreshing and reinforcing them and trying to think about that population health management approach. So think about what are the long-term outcomes for mums and for families and for babies within the city, and where do we want to improve, and particularly having a mind on health inequalities essential to that, and using this opportunity of learning and reflection after COVID to enhance that work. Shall I hand over to you, Liz?
Yeah, thank you. So we just wanted to give you some examples of some things that have happened over the last year, which we think are really good examples of this partnership work, like Emily just talked about. So one of our key work streams under the maternity strategy was reconfiguration and supporting the centralisation of maternity services to the LGI in the future. We have developed a really innovative partnership with libraries and community hubs that are run by libraries to develop healthcare and wellbeing hubs, which are a really nice, welcoming, homely space for us to deliver maternity and other healthcare services out of these hubs while still being clinically appropriate for our teams in using them. And that will help us really consolidate our maternity services and make sure that we're in the right place to be able to have the estate to deliver maternity services closer to home, and particularly in areas like Hare Hills, where we might be moving away from providing maternity services at St James's. That's a really exciting development for us. In terms of our perinatal mental health work stream, we've continued to expand the funding that's gone into our specialist perinatal mental health service. So we're now able to support more women and families with moderate to severe perinatal mental health issues. We've also worked across West Yorkshire to develop a pilot, what we're calling a maternal mental health service. And that service is supporting people who wouldn't traditionally be supported within perinatal mental health services. So perhaps those families who've suffered from bereavement or stillbirth, or who've had children removed at the point of pregnancy or birth. In terms of reducing health inequalities, LTHT have employed a public health midwife, and we've got a lot of energy together across the city around making sure that we're working really closely with different communities on what's going to make a difference to them in terms of maternity services and improvement. And we're working through our Leeds-wide health inequalities framework to develop a work plan for that. We've also got a really rich source of data now within LTHT, with something that's called a PLIX dashboard, and that enables us to have a look at lots of different factors about what's influencing people's outcomes so that all the changes we make can be really evidence-based. And in terms of preparation for parenthood, we have some really exciting public health joint initiatives that we've done over the last year. So we've just started the process of employing some new stop smoking advisors that are specifically dedicated to maternity, so they can work really closely with our maternity services and hopefully influence rates of smoking at the time of delivery, which we know is one of the biggest modifiable factors for our stillbirth rates in the city. That's quite a whistle-stop tour, but.
Thank you very much. Emily, do you want to come back?
Thank you. No, I think what we'll do is either at your discretion, Chair, take further questions here or move on further to the LTHT update in detail and then take questions after that.
Yes, please. We would like to hear from the Leeds Teaching Hospital Trust staff, if that's all right. Is it yourself, Dr. Everett, or Claire, or both of you?
Be Claire first and then me, I think.
Go for it.
Unmute myself. Can you hear me, everyone?
We can.
Yeah. So I'm going to just pick up briefly about the fertility clinic that you wanted an update on. So we came to see you in March 2021, and at that point we were discussing our IVF clinic, which is run by LTHT and saw a mixture of NHS and private patients. We described at the time that we were seeing increased competitions from other private clinics, that we were expecting private clinics to come and set up in Leeds that they hadn't done at that point before, and that we'd already started to see a reduction in NHS cycles in terms of cycles of IVF activity, and that we were anticipating that we would see a reduction of further cycles if these private clinics were indeed set up. And so we told you that we were planning to go out to tender to see what other services might be able to provide that for us. We did that, and we published the tender in I believe May 2021, and we did some public consultation. I think we discussed with you at the time that we were talking to our patients about what was important to them. They described themselves as being very happy with the clinic and with the care they were receiving, but they thought there were improvements that could be made with communication, the administration of the service, and the fact that we weren't yet able to provide some of the patient apps on the phone and digital applications that support people going through their IVF journey. And other competitors were much further along in being able to offer that kind of digital information and stuff that improves the patient experience. We received high quality bid from a company called Care Fertility, who are big providers in the UK of this of IVF care. And we did an in-depth quality and financial analysis of the next 10 years, and we compared the care bid against continuing to run the clinic ourselves versus and using some information that we gleaned from other cities, looking at how what happens when private clinics come into the cities and what happens to activity. What we decided when we were doing this was that the best option was to award the contract to Care Fertility, and we decided that for 3 reasons really. We felt that they're a really high quality organisation and they deliver very high quality care. So we didn't believe there would be any concerns regarding what care patients would provided would receive there. We felt that financially for us as an organisation, it was the least bad option. I just want to emphasise that none of the options we looked at meant that Leeds Teaching Hospitals made money from any of these options. This is the least bad one for us as an organisation. And we also felt that Care Fertility had a really good focus on the patient experience, which was something that we knew patients were saying that we could do more about, and they have a really good patient information digital applications that support patients through their care. So we awarded the contract to Care Fertility in February of this year, and staff who had worked for us TUPE'd over on their NHS terms and conditions. The unions were fully involved in that process. The consultation with staff was undergone. And so we wanted to update you what's happening now for the clinic. So there's very little, if you're a patient, there's not a great deal of change that you will have noticed as a result of the change, beyond the fact that Care are now the provider of that service. So NHS patients still access their care from that clinic. The team who look after you are the same team that did it before. And there's continuity because the NHS consultants who continue to work for Leeds Teaching Hospitals do a little bit of their time at the Care clinic, and they see and treat the patients who've been referred there. So the patient remains under the same consultant as well. All the contracts mean that the same number of patients we're expecting to see are treated in the Care clinic. And for this, I asked the Care clinic to provide me with some patient experience data to see what patients were saying about their care. It's almost universally excellent, really high quality, and they're really happy with the quality of care. They are happier with the way it's administered now than they were at the time. And we've noticed a reduction in some of the waiting times for some key tests that Care have done on our behalf, which has really helped us because, as you know, in the NHS, we've got very long waits and backlogs. There are still some backlogs for fertility outpatient appointments at Leeds Teaching Hospital, but as soon as the patients are transferred over to the Care clinic, they're seen very swiftly, and we have no concerns at all about waiting times. So really, that's just a summary of where we're up to with the clinic.
Okay, thank you very much, Claire. And I do remember that meeting, obviously, with the fertility clinics. What I would like to ask, obviously, the takeover has only been very recent, so it's a very short time. When you said you've asked certain patients questions, how many did you trial in terms of asking? What's the data?
Okay, so the data is that Care do a questionnaire for every single patient, NHS or private, that they treat. They've provided me with about a month's worth, but we are just about to start we have regular contract meetings with them because we have a contract with them to provide that care. They're expected to provide their patient experience data for every month that we have it, every single time we meet. It's been built into all of the core contracts we have with them, that we expect what level of quality we expect, and we require detailed information about patient experience, patient complaints, any issues, so that basically we can ensure that any issues or concerns are flagged and are being dealt with appropriately.
Okay, thank you. In terms of affordability, any move on that one?
In terms of how affordable are the cycles for patients?
That's right, yeah, because we did speak last year. I'm still trying to remember, we did speak because women are entitled to only so many cycles depending on your circumstances, isn't it?
Yeah.
So I do remember. Sorry,
yes.
go on.
So the commissioning decisions that's taken by the ICB and by other CCG or old CCGs in the region remains the same, which is if you are eligible, so it's only certain groups of people are eligible and they can have one cycle of NHS IVF treatment. So that is not anything to do with Care, that is to do with our own ICB's decision about what they want to pay for. The private costs are slightly different. So Care for private patients, it's difficult to compare because they cost the packages differently to the way that we did. Some bits are more expensive, some bits are cheaper.
Yeah, I am still concerned about, when we keep talking about health inequalities, which is one of the things